Hello, welcome everyone. Today we are going to be discussing ensuring optimal IBD care in the era of COVID-19. Your presenters today are myself. I'm Jessica Allegretti, and I'm the Associate Director of the Crohn's and Colitis Center at Brigham and Women's Hospital. And joining me today is Dr. Miguel Reguero, the Division Chair of Gastroenterology at the Cleveland Clinic in Ohio. Our program information we have provided by North American Center for Continuing Medical Education, and this program is supported by an educational grant from Janssen Biotech. Our learning objectives today are to examine the benefits and risks of currently available treatment options for patients with IBD with regard to heightened immunosuppression concerns during the COVID-19 pandemic. We are going to utilize virtual visit technology to conduct assessments and monitoring of patients with IBD whenever possible, as well as leveraging recommendations and resources to assist patients with IBD in medication administration, disease monitoring, mental health, and other services during the pandemic. So to begin, an overview. In December 2019, numerous people in the city of Wuhan, China, developed infection and respiratory symptoms. This virus was ultimately designated as SARS-CoV-2. The World Health Organization subsequently named the disease produced by the virus SARS-CoV-2 as COVID-19. Shortly after this, unfortunately, it spread throughout the world. As you can see here, this is a map provided by the CDC as recently as May 27th was when this was accessed. And you can see the distribution of cases throughout the United States, with the dark purple being the densest population of cases. And again, as of May 27th, there were over 1.5 million new cases in the United States and almost 100,000 deaths reported. This is a map of the IBD reported cases to date. This is from the Secure IBD Registry, which we're going to be discussing a bit later. But you can see here the density of IBD cases with COVID-19 reported throughout the U.S. SARS-CoV-2 is thought to be transmitted via droplets and possible by airborne inhalation of aerosolized particles. Additionally, transmission of COVID-19 can occur by contact with surfaces contaminated with respiratory droplets. It's thought that the incubation period is between 1 and 14 days, with an average of 5 days. The R0, which is thought to be how many people can be infected by an infected individual for this virus, is between 2 and 3. And it is known that symptomatic individuals are more infectious than asymptomatic individuals. However, about 2/3 of those infected have mild disease, as you can see with the figure here on the right. I do think it's important when we think about this disease process to understand the different stages of this disease, especially as it pertains to inflammatory bowel disease. And what you can see is the initial stage is the viral response, and that is when patients have often mild constitutional symptoms, fevers, and then later in the disease course is when we move into the inflammatory response. This is when we see people with respiratory failure, shock physiology, often in the ICU, requiring ventilation. The reason why this is relevant, as our IBD patients, because of their potential immunosuppression, may be at risk for this viral response phase. However, when you think about the inflammatory phase, and many of the therapies our patients are on, they may be somewhat protected or at less risk for developing this inflammatory response. And so this is something we'll discuss as we go through this program. What are risk factors for bad outcomes? Already we know from data collected around the world that older age and several high-risk comorbidities like obesity and diabetes certainly do put patients at higher risk. And this is a study that looked at obesity as an independent risk factor for SARS-CoV-2 severity. And as you can see, patients with higher BMIs certainly were at increased risk. So when to suspect COVID-19, certainly patients with cough, shortness of breath, or difficulty breathing, or at least 2 of the following symptoms: fever, chills, muscle pain, headache, sore throat, loss of taste or smell. Certainly known exposures to infected persons. There are now sort of more classic abnormal chest imaging findings, such as ground glass opacities, and lab findings such as lymphopenia and elevated CRP have been noted in this disease. So what about GI symptoms? In this study, as you can see, they looked at patients with GI, respiratory symptoms, or the combination of the two. And what's certainly notable is that a majority of the patients with GI symptoms also had respiratory symptoms or no GI symptoms with respiratory symptoms alone. This small sliver in red here is patients who had digestive symptoms without any respiratory symptoms, but notably, many of these patients had fever. This is a study from my institution up in Boston, and what's notable here is that these were all of the patients that came through our hospital systems with confirmed COVID-19, and 61% of patients had any GI symptoms, with the most common being anorexia and diarrhea. SARS-CoV-2 does use the angiotensin-converting enzyme 2, or ACE2 receptor, to enter into cells, and we know that ACE2 is present in the enteric epithelial cells. The virus is detectable in the stool. However, there are no good viable stool tests yet being used commercially, although I do think those are coming. And we know that the virus can be detected in the stool even after the nasal swabs can be positive and there is a clearance of respiratory symptoms. More recently, there has been live virus detected in the stool of patients with COVID-19, and so this certainly raises the possibility of a fecal oral route as a possible mode of transmission. So again, when we think about GI symptoms, especially in our patient population, there is a high prevalence of nonspecific GI symptoms in patients with IBD. And so it's important to note that if a patient is coming to you with new digestive symptoms, but they have not developed either fever or respiratory symptoms, that's a patient you should monitor closely, but don't necessarily need to rush to test for COVID-19. However, if progression of symptoms occur, then certainly consider testing and making treatment adjustments as needed. So are our patients at higher risk? We know that they certainly are unique in that many of our IBD patients are treated with immunosuppressive or immune modifying therapies, and our patients certainly have a lot of healthcare exposures. They're often in infusion centers frequently, they're getting routine labs as well as endoscopic procedures, so they do interface with healthcare facilities quite often. We also know that many of our IBD therapies already carry a risk for viral infections. For example, there's an increased risk of zoster with tofacitinib, risk of reactivation of hepatitis B with anti-TNF therapy. Viral warts are associated with thiopurine use, and we know that IBD patients have an increased risk of influenza. So this leads to several questions regarding the management of patients with IBD. For instance, what is the risk of infection for SARS-CoV-2 in this patient population? Does active inflammation increase the risk of getting infection with SARS-CoV-2? And what is the risk of developing symptoms of COVID-19? Do our patients have worse outcomes when they do become infected? And do our IBD therapies increase risk? And a big question I think that many patients are asking is, are any of our IBD therapies actually protective? And should we be modifying IBD therapies? Given how many questions there were in this space, and given the lack of data initially, the International Organization for the Study of Inflammatory Bowel Disease published some guidance to help us really think through how to manage these patients. And I'm going to be walking you through some of this guidance now. So some summaries from the IOIBD guidance. 1, the risk of infection with SARS-CoV-2 is the same in patients both with and without IBD. Independent of treatment, patients with UC and Crohn's disease do not have higher risk of infection with than the general population. It is still uncertain if active inflammation from IBD increases the risk of getting SARS-CoV-2, and patients with either an ostomy or a J pouch are not felt to be at increased risk for developing COVID-19. So what about therapeutic considerations? Our patients with IBD who do not have infection should not discontinue their IBD therapy. Patients should continue infusions on schedule at appropriate infusion centers. And the goal still is to sustain remission both clinically and endoscopically. We want our patients to be advised to maintain their current regimens, again, to avoid relapse due to non-adherence. We certainly want to keep our patients well to hopefully avoid unnecessary ER visits or hospitalizations that could have been avoided. And patients still should maintain social distancing, working from home when possible, meticulous hand hygiene, and separate themselves from known infected individuals. And again, this practice may vary state by state based on governmental guidance. Patients with moderately to severely active Crohn's or ulcerative colitis, whether it's a new diagnosis or relapsing disease, should be treated with the same therapies you would choose in the pre-COVID-19 era. So you still have all of your options available to you when treating a new patient. So I know this seems like a dense table, but I do just want to walk you through some of the highlights. Again, this is from IOIBD and is available on the web. The website is here below for those who are interested. So again, for our patients who do not have infection, whether they're in remission, have mildly active disease, or severely active disease, we really do want to limit prednisone use, taper or discontinue when possible. Sometimes that may not be possible for patients with severely active disease, but you certainly want to limit use whenever possible. What about patients who do test positive for SARS-CoV-2 but do not have symptoms of COVID-19? These are patients, especially if they're stable, where you may want to wait or withhold therapy for up to 10 days to see if they're going to develop symptoms of COVID-19. Certainly, if patients do have disease activity and they need therapy, consider things like budesonide, 5-ASAs, and rectal therapies in the meantime, while you're potentially holding immune therapies to see if disease is going to develop. For patients with symptoms of COVID-19 who are not hospitalized, again, therapy considerations will be determined based on how active their IBD is, but this is, again, a patient population where you would consider holding therapy until their symptoms have resolved, and we're certainly going to discuss when and how to consider restarting therapy. Probably the most challenging patient population is our severely ill patients with COVID-19. And of course, the primary focus in this patient population is going to be supportive care for COVID-19. Certainly if they're getting ventilatory support, life support, those are going to take precedence to the treatment of their IBD. However, if patients do have concurrently severely active IBD, certainly you can consider treating. There has been some data to support the use of cyclosporin in UC, given there may be some benefit against coronavirus. But again, we're going to try to limit the use of steroids whenever possible. So again, just to reconfirm and to summarize here, patient who has IBD and confirmed COVID-19, if the patient has COVID-19, whether it's mild or not, and has digestive symptoms, it's important to remember that on top of the supportive care you're doing for the COVID-19 symptoms, you need to investigate the cause of digestive symptoms. Remember, not all patients with COVID-19 are going to have GI symptoms, so you want to make sure you're not missing other things. So you want to be excluding these patients for other infections, certainly like C. diff. You want to confirm active inflammation. Is this an IBD flare, or is this just purely symptoms of the COVID-19? So using things like C-reactive protein, fecal calprotectin, or cross-sectional imaging when possible. However, being aware that both C-reactive protein and cross-sectional imaging may be altered in the setting of COVID-19. If the results do suggest relapsing of IBD, treatment again should be based on the activity of the inflammation and severity of the IBD, depending on if you feel that you can wait until the COVID-19 symptoms have subsided. Now, what about considerations for restarting therapy? You know, we're having many patients who have developed COVID-19 and are coming through it. On the other end, we have to make decisions about when to get them back on therapy. I think what's important to note is that many of our patients, and we're starting to see this trend, will continue to shed even after their symptoms have resolved. And you may see that patients have continued PCR positivity based on nasal or oral swabs, even once they've become asymptomatic. And this does not necessarily correlate with positive viral cultures. So therefore, this positive PCR testing does not always indicate active infection, and you may actually be swabbing dead virus. We aren't completely sure. And so whether immunocompromised patients are at greater risk for prolonged shedding is still unknown, although there is certainly investigations into this currently. And so I think many of us have moved towards a symptom-based strategy when considering restarting therapy rather than relying solely on a test-based strategy. And so you want to time recommencement with consideration of both the patient's IBD and COVID-19 severity. And so I will walk you through this graphic also from IOIBD, which I think really helps think through some of these steps. Again, if the patient has no symptoms and there's no testing been done, don't withhold therapy. Try to dose reduce steroids when possible. If the patient has no symptoms but does test positive for SARS-CoV-2, consider withholding therapy if possible for a minimum of 10 days to see if symptoms develop, and if they don't, then certainly resume therapy. For patients with positive symptoms for COVID-19 as well as a positive test, certainly you want to withhold therapy until their symptoms have resolved. And what does that mean? At least 10 days have passed since the COVID-19 symptom onset, and you want to make sure that patients have had at least 3 asymptomatic days, meaning they have no fevers, they're ultimately feeling well, and their respiratory symptoms have improved. This timeline may change for patients with severe COVID-19 or patients who have recovered from an ICU stay. You may want to lengthen that timeline to give them further recovery from their COVID-19. And again, if your institution is mandating a test-based strategy, what does that mean? It essentially means that patients need to have 2 negative either nasal or oral swabs at least 24 hours apart before resuming therapy, whether that's outpatient therapy or potentially coming back to their infusion centers. Although I can tell you, I do think many centers are moving towards a symptom-based strategy, which I would highly recommend. So now just to review some real-world data, what's actually available. So as I mentioned, this is the secure IBD database. This is a database available to the public. Any provider around the world who wants to enter data from patients with IBD who have developed COVID can. And so again, you have to take that into consideration. These are cases that providers have chosen to place into the database. But as of May 26, which is when I accessed this last, there were about 1,300 cases reported to date and about 444 in the US alone. And you can see the case density again here by state, with New York being the highest. When looking at medications, you can see here, this is looking at various outcomes. This dark blue color is a composite outcome of patients who either required ICU stay, ventilator support, or ultimately died. And what you can see here is there certainly is a trend with patients who received oral or parenteral steroids having more severe outcomes with their COVID-19. There does also seem to be a signal with 5-ASAs. And that may seem odd to you, but what is thought to be represented here is potentially patients with more significant comorbidities or a sicker patient population may be more likely to be receiving mesalamine therapy. When looking at other risk factors, what you can see here is that as with many other patient populations, we're seeing elderly patients at high risk for more significant outcomes. And then we're starting to see a signal here as well that patients with moderate to severe active inflammation may be at higher risk as well. And we are certainly seeing that with other chronic illnesses as well. Again, just really supporting the fact that we want our patients to be well controlled. We want our patients in remission to ultimately have them be as healthy as possible. I do just want to point this out. This was just published in Gastroenterology, and this is the first set of data that has come out from the secure IBD registry, and this was their multivariable regression model where they looked at outcomes, again, for that composite outcome of COVID-19. And what we're still seeing, again, is older age, systemic corticosteroid use, and multiple comorbidities seem to be the highest risk for patients to have severe outcomes with COVID-19. We're not seeing signals for anti-TNF use, and certainly just having the diagnosis of IBD, either whether it be Crohn's or ulcerative colitis, we're not at risk. So I do just want to end on some emerging therapies of interest that you may be reading about or your patients may be asking you about. And so the IL-6 pathways has been one of interest. And so therapies targeting IL-6 have been used to treat what is called cytokine release syndrome. This is an FDA-approved indication. And so the thought was, because of the inflammatory response seen in COVID-19, perhaps drugs in this pathway could be used to reduce that inflammatory stage and ultimately reduce COVID-19 mortality. Tocilizumab is a therapy that is approved to treat rheumatoid arthritis. There are approximately 40 trials ongoing looking at this agent in COVID-19. And I'm just sharing data here from a retrospective analysis of COVID-19 patients who received a single dose of tocilizumab. And you can see that they did have improved outcomes compared to those receiving standard of care, although this was non-significant. There is also saralimab, which is an anti-IL-6 receptor agent, and there are 10 ongoing trials looking at this agent as well. What about our JAK inhibitors? Certainly, this was something we had concern about initially. Is this agent making patients at higher risk, or is it potentially protective? One agent, baricitinib, is thought to potentially interfere with virus entering the cells. And so there are several ongoing trials looking at this JAK inhibitor. Less so with tofacitinib, although I did just want to highlight this. This is a trial that is ongoing in Italy right now, looking at tofacitinib at potentially preventing pneumonia with SARS-CoV-2. So I do think there is a lot of data that will be emerging with some of the therapies that we're already using. And I will just end with remdesivir, which I do think is something we're hearing a lot about. I'm certainly getting asked a lot about. And the first randomized controlled trial looking at this agent was just published in the New England Journal of Medicine, so I wanted to share the data. This is not an anti-inflammatory agent, but an antiviral medication. It is an RNA polymerase inhibitor, and the RCT that was just published had over 1,000 patients in it that were randomized to either receive this agent or placebo, and they were able to show that a median recovery time of 11 days with receiving remdesivir as opposed to 15 days in placebo. However, the mortality benefit, while it was lower in the treatment group, was not found to be statistically significant compared to placebo. So I do think this is promising. I do think we're going to see more use of this agent, especially in our ICU patients. And I do think there are going to be several other agents that are coming down the pipeline that will be of interest. So stay tuned. And with that, I will now turn it over to Dr. Ruggiero.
Thanks, Dr. Allegretti. That was a wonderful presentation and a good background to GI and IBD as it relates to COVID-19. We're going to shift gears a little bit, and I'm going to get into the telemedicine monitoring and some of the patient care aspects in our practices in the era of COVID-19. It's hard to believe that the front page of telemedicine was as of recent as June of 2016. It almost seems that things that happened about 3 months ago feel like 3 years ago. So certainly 2016 doesn't feel like 4 years ago, but a lifetime ago. But this is really when telemedicine started to emerge. When we consider the telemedicine and where we are today, and certainly most of us are now using telemedicine in some form in our practices with COVID-19, but when we consider the digital origins of telemedicine, and it's interesting to see the big companies on the left-hand side of this slide, but really healthcare has not kept up with consumer electronics market, and this is something that we have relatively lagged. Telehealth has been published, and I refer you to some articles. This is one from the New England Journal of Medicine in 2017, which again feels outdated, but I thought this was a nice overview to telemedicine. And it really talks about the different aspects of telemedicine as we know them and as they have emerged. So just to pause on this for a minute, the traditional telemedicine on the left-hand side are rural clinics where patients would go to a physician's office to seek additional consultation through telemedicine platform because they couldn't drive to maybe a tertiary or quaternary center. So rural clinics where they would be seen for specialty care, radiology care, even for some urgency care. And that's the traditional aspect of telemedicine. Asynchronous telemedicine includes patient monitoring through remote monitoring, and this is really a one-way platform, so the patient will either enter information or data, and this will then essentially get beamed towards a receiver. And then finally, synchronous, which is what most of us are doing today, which are live video to cell phones or video to platforms. And the synchronous involvement is connecting with the patient. Again, the patient logs on to an app and their different platforms, pays a copay, and from a practical standpoint in our Q&A session, this may actually come up, and then enters this waiting room. The provider and staff are alerted when the patient's ready in the waiting room, and then the visit begins. And again, all of us have done this in some form. Usually the patient and provider will be placed into a video conversation, and the visit is actually conducted. Depending on the platform, we use Epic, and I know many of us across the country use Epic, but there are different electronic medical record systems that now integrate with telemedicine. So why do we even consider telemedicine? And this was really even emerging before COVID-19. And this is a bit of a joke slide, but at the same time, this is really what patients are thinking about. So the focus is, if we're looking at what's most convenient for the patient, what's most patient-centric, and we consider the drive or travel to the clinic, there are side effects that come with this, and this is, again, something that we don't necessarily consider, but patients need to take time off from work so they lose wages. There have been accidents, unfortunately, on the way to or from the visit, whether it's in the car or other modes of transportation. They need to pay for gas, child care for some. There are other personal accidents that can occur in terms of some need to actually stay in hotel rooms. We've had patients actually have to pay quite a bit of money to come in and see somebody. So this can be a scary and costly time to actually come to an in-person visit, and telemedicine has really replaced that. Well, it took the crisis of COVID-19 and the pandemic that we are currently in to see the exponential growth of telemedicine literally overnight, and certainly over the course of 1 to 2 weeks. And again, I think for those listening, you've all been involved in telemedicine in some form. This is actually a very recent article that was just published, again, in the New England Journal of Medicine, looking at telemedicine for COVID-19. I put the reference here, but this is a nice overview or editorial of telemedicine in the era of COVID-19. We also, and Jess alluded to the IOIBD consortium, myself along with some of the other physicians actually looked at telemedicine and the impact of telemedicine on IBD, and I'll show you in the next few slides some of the results of this international survey. Jess did a nice job of outlining some of the treatment modalities from the IOIBD survey and some of the publications. Well, this is a survey that we put together. We had over 700 gastroenterologists mainly, although there were some nurses and surgeons who replied to this survey, most of them in the public sector, but some in private and public and private. This was an interesting finding. This is the mode of patient delivery during COVID-19. And just to orient you to this world map and the colors, the green are face-to-face in-person. So this is the traditional in-person clinic visit. Blue is telephone, and then red are the video or the virtual or telemedicine visits. And it's interesting to see that there has been definitely a shift away from green in most places, which is, again, the face-to-face in person, towards telephone, and then even the pink or the red, which are virtual visits. And you can see different countries. So, for example, the United States, I think the United States, the majority of the electronic or digital care has been delivered by video or some type of telemedicine or virtual platform. Reimbursement, is reimbursement an important factor in the setup of your clinic? And this was again based on the survey, where yes is blue, red is no, and then orange is sometimes. Now I will say that this is dependent on countries. So for example, in the United States, there was a higher rate of blue or yes, reimbursement's important. And this has been historically one of the questions about telemedicine in the United States and in the world in terms of reimbursement. But with the COVID-19 pandemic and many of the payers and insurers, at least in the United States, waiving some of the restrictions and essentially paying for telemedicine, this has been very helpful. When the surveys were done, do you have the option of video consultations for clinics? Interestingly, is about half and half. About half of the world does not, and about half does. And again, I think in the United States, there are the option for video consultations for clinics. This is a bit of a busy slide, but I'll orient you this as well, because this asks the question about before COVID, during COVID, and after COVID, what people would be interested in doing. So just to orient you on the slide, the top bar is prior to COVID, the middle bar is during COVID, and then the bottom bar is what would be the plan after COVID. Green is face-to-face, blue is blue is telephone, and then red is video, and then gray is uncertain. So you can see prior to COVID-19 in the top bar, most of us were doing face-to-face in-person visits, which again switched during to at least some type of telemedicine or video platform. But it's also interesting to see that many, or more at least, will plan to continue to do some types of virtual or digital communication with patients after COVID-19, although there still is a large percentage of in-person. I actually did a Twitter poll, and I know some of you participated in this, asking the question, when you are able to see patients again in person, what do you plan to do? The orange is stop telemedicine, green is do some telemedicine, meaning keep some in the practice, and then blue is more telemedicine. And this was interesting that only a small percentage of people said that they would actually stop telemedicine, where most of us are planning to continue some, and I would dare say most are continuing to have some type of hybrid access with in-person clinics and telemedicine, and certainly in my practice, that's what I would plan. Well, what about the patients? Are the patients interested in this? And the question that I posed, again, as a Twitter poll, which I realize methodologically is not perfect, but it gives us a bit of a sense of what people are interested in. When we ask the patients, when I, the patient, am able to see my doctor again, I prefer to do, and you can see that the preference is blue is both, some in-person and some telemedicine. Orange is actually telemedicine, and green is in person. I should say that when I've actually spoken to my patients and done telemedicine, there's a high preference to these. Even some of our new visits, which I was concerned about, many of our patients like this. I do say that there are patients when they're very sick or they need a physical exam. That's the limitation to telemedicine. But otherwise, patients do seem to enjoy this as well. This is just a graph to show you the overnight switch to virtual visits in specific GI practice. This is ours, just for full transparency, at Cleveland Clinic, where the beige is in person and green is virtual or telemedicine. And you can see that on March 17th, we almost flipped the switch to change from in-person visits to telemedicine visits, and our access or our volumes were lower, but we're not too dissimilar to what we were doing in person visits. And then as a healthcare system, in February, the virtual visits, which were prior to COVID-19, were about 5,000 per month across our system. But then in April, it was over 200,000 per month and seems to even be going up now that we're even getting back to in-person access. So just an example from one healthcare system. What are the pros and cons of telemedicine? Well, the pro is, I think, most from a patient and a provider side, it's convenient. It's obviously safe. It allows for the ultimate social distancing because there's absolutely no contact whatsoever, and can be an adjunct to routine care. So there's been metrics that have been studied, and I have a couple of references at the bottom that include improving quality of life, adherence to therapy, medications. Telemedicine even may actually decrease hospitalizations by allowing the healthcare team to see these patients more frequently. What's the downside or the con? There is no direct human interaction, although I think many of the video-capable screens and technology have overcome that to some degree. There's still not the in-person touch part of this. I think from a provider side, probably the biggest concern has been over reimbursement, is obviously will this reimbursement stay the same in the COVID era, which seems to be a close to one-to-one reimbursement as we were seeing for in-person. Will this exist after? And then obviously the physical exam, although there is the ability to do a component of visual physical exam with telemedicine. Obviously, we can't palpate, we can't directly inspect certain areas of a physical exam. And then finally, a big con is access to technology and equipment, not just on the provider side, which may not be as much of a limitation, but certainly on the patient side, and some of our patients do not have access to this technology. Well, we were also interested in looking at point-of-care contact. So I'm moving a little bit from telemedicine into remote monitoring. And the IOIBD group looked at monitoring during the pandemic and access to fecal calprotectin testing. Jess mentioned fecal calprotectin related to COVID, but obviously we know that this is an inflammatory marker that we can measure that does correlate with active inflammation in the GI tract. 47.1% of people who were asked had reduced or no access to fecal calprotectin testing during the COVID-19 pandemic. Prior to COVID-19, nearly 90% had routine access, and then during COVID-19, you can see the drop-off on the bar graph, but also at below. And the bottom line is that this just has to do with difficulty in terms of testing and going to the lab. I will say that point-of-care testing in some places in Europe that can actually do point-of-care at-home testing has been really something that I think is novel and innovative prior to COVID-19 and certainly was utilized quite a bit in COVID-19. This is just an overall summary slide to remind people that the IOIBD consensus statements, and Jess already went through some of these in terms of treatment. The website is there, the IOIBD.org, which is a very good website for updates specific to IBD. There was a RAND analysis that was done in terms of overall treatment. As Jess showed you some take-home slides from IOIBD, this is not meant to be something that I'm going to go through in detail now, and I know is difficult to read on your screen, but for those that want a single page, and you could print this out on telemedicine setup, it goes through the overall nuts and bolts of pre-visit preparation, during visit, addressing technology changes and challenges, after the visit documentation, and we do get a little bit into billing and payers as well, which is, I know, a very hot topic for people and may come out in the Q&A. I did also want to mention that we talked about treatment and infusion centers. Again, this is not meant to be read necessarily, but I wanted to reference this from IOIBD and briefly tell you during the time of COVID, I have not changed my personal infusion practice. I do recommend that if a patient needs to start an infusion, whatever that therapy may be, and I feel that that's the best medicine for them, that I will do that. We do have them come to the infusion center. I think the infusion centers across the country have been excellent in terms of social distancing, preparation, hygiene, mask wearing, and this is really something when I tell my patients that this is probably one of the safer places to come given the awareness around infusions. Some patients get home infusions. I'm not preferentially doing home infusions just because of COVID-19, but if somebody's on home infusions or the insurance requires home infusions, the home infusion agencies have also been very good with this and is not something that I would not do just because of COVID-19. We are not, and this might come up in the Q&A, we are not necessarily testing all of our patients before biologics, but when we go through the discussion, maybe Jess and I can both give our opinion on that, but we're not necessarily doing that a priori in asymptomatic patients in terms of testing for COVID-19. And then finally, I just have a few more slides. The pandemic has really allowed for creativity and innovations, and as some of you may know, we've developed and others have developed these medical home for IBD, which is really a multidisciplinary care approach to inflammatory bowel disease patients, which had relied on a group visit, meaning patients would come into the office and see a number of providers for one-stop shopping. This has been very interesting in that I was concerned about this, but we have been able to switch innovatively through telemedicine and virtual care, and I know many centers have done this as well, in that we can actually either do sequential visits through different electronic platforms, meaning that patient sees me and then they might see the dietitian and they might see the psychologist as they would in a normal clinic, or we can actually split up the visits over a period of time. And I actually thought that that was going to be a detractor, but we have actually found that patients, sometimes when they come in and meet with so many people, while they like the one-stop shop, they didn't actually necessarily absorb all the information because it was so overwhelming. So actually splitting up the visits, and with many patients who are still needing to be at home, they actually told me, one of my patients the other day said they didn't mind seeing me one day, the dietitian a few days later, psychologist at some point, surgeon at a different time. They actually felt that those little snapshot visits were somehow more actually educational, and they retained even more. So just interesting innovation. I do think that the future is now in terms of telemedicine. Again, I know we're all seeing this. This is something that is truly here to stay. I do think one of the big questions is going to be paying for these. My sense is that the video telemedicine visits will continue in a reimbursement strategy that is favorable to continue. The question will be the copay, and the question will be, what about non-true virtual or video visits, such as telephone calls or other platforms that are outside of a virtual or telemedicine visit. And then the final, actually second to last slide is there are a number of resources out there. These are just a few. This is not meant to be comprehensive. I mentioned already IOIBD, the Crohn's Colitis Foundation, the CDC, ACG, AGA, ASLD. Pretty much every society has something that's been very helpful on COVID-19 in terms of resources, and although Jess and I focused a bit more on IOIBD, this is just to round out some of the other opportunities. And then finally, I thought this was a joke, but one of my patients actually said this, that they wanted to list their iPhone as their primary care doctor. So just a little bit of humor in the era of telemedicine and where we're headed virtually. So on behalf of Jess and myself, thank you for your attention. I hope this overview on IBD and COVID-19 and some of the practice management aspects of COVID-19, including telemedicine, monitoring, infusions, has been helpful to you, and we certainly look forward to the Q&A session. Thank you very much.
All right, everyone. Thank you for joining, and we're going to now start the Q&A portion. So feel free to submit any questions that you may have. and we will do our best to answer them. The first question, and Miguel, I will throw this to you. Most recent studies have shown that steroids do have a place potentially in the treatment of COVID-19. That being said, why are we sort of insisting on taking IBD patients off steroids currently?
So that's a very good question. And again, for all those that were listening in, thanks for joining us today, and hope everybody's safe and well during this time. So the question comes up, some of the medicines that we're actually using for COVID-19 are immunosuppressants and steroids, and the one question of why the steroids. So some of this is based on the secure IBD registry and the knowledge that we have currently in patients who had IBD, were on 20 milligrams of steroids or higher, prednisone or higher, who actually had worse outcomes in terms of their COVID-19. So this is based on totality of experience and data, which is only about 3 or 4 months old, unlike many other diseases where we can cite years of data. Everything is very new, but there were worse outcomes at higher doses. Nonetheless, are there patients in ICUs with COVID-19 independent of IBD who are treated with steroids or anti-interleukin or anti-cytokine therapy? Yes, but we have found so far that the higher dose steroids do make the infection worse, and we have seen this with other IBD disease states and infections in the past.
Great, and there are some similar questions here about the protective nature potentially of some of our IBD meds. Have we found that any have been protected? And as we discussed earlier, it may be that some of our IBD meds, because of the blunting of the immune response, limits that inflammatory phase of the disease. Although I do think using the word protective may be sort of over-characterizing what we're seeing. I don't know that we can say that necessarily yet. But again, as Miguel was just discussing, through the secure IBD registry, we have been able to see that patients on other therapies aside from higher dose steroids don't seem to be at risk for this sort of composite bad outcome, being ICU stay, ventilator status, or death. So that is certainly reassuring.
Yeah, and just to add to that, and actually, Jessica, my presenter chat just popped up, so I'm live
Good.
with you also. But there was, interestingly, there's a study that's being planned and has not, to my knowledge, been yet executed in China, looking at actually anti-TNF therapy for potentially COVID-19. So the person asking the question's asking an interesting question about anti-cytokine therapy that we use for IBD, whether this will be effective. But I completely agree with what you said.
Yeah, and absolutely. And just to that follow-up point, I believe I showed the slide. At least there's a study in Italy also looking at Xeljanz and potentially reducing risk of pneumonia in COVID-19 patients. So I think there's certainly a lot of interesting exploration with a lot of the IBD and anti-cytokine therapies as well. So it looks like here, next question, risks of non-urgent routine screening colonoscopy for Crohn's now with COVID delay, sort of timing of that. Miguel, I know you talked a lot about telehealth. Sort of how are we thinking about when to start bringing our patients back for routine screening care?
I think it depends where you are in the country. So I imagine, Jessica, I'll wait and hear what you say in Boston. And for those listeners in New York City, it's going to be very different than, say, Cleveland. Yeah. So we actually started, within the last 3 weeks, we actually started opening for really all business, including screening colonoscopies. Just to give you a little bit of tidbit information, in patients who are asymptomatic, who are tested for COVID in Cleveland, so this is where geography matters, the rates of positive testing is 0.4%, whereas in New York City, the testing has been as positive or prevalent as 15%. So I think if you're in an area where geographically the rates of COVID have been very low, your ability to come back and start screening procedures like colonoscopy may be done quite early or much earlier than, say, other places. So curious to hear how you in Boston are answering this question.
Yeah, so I would say surprisingly similar but different. So we are open for business as well, and that we did a sort of a slow rollout a couple of weeks ago. As I'm sure many of you, we delayed a lot of cases, over the last 3 months, and we've been keeping track of all of those. We essentially ranked things from basically what we called, sort of tier 1 to tier 4. And we're trying right now very hard to get all the urgent patients that were potentially delayed because of COVID in right now. And then we will start to do more elective type cases, more likely in July and August. But all of our rooms are fully open. We're sort of back to full capacity in our endoscopy units because of the prevalence in Boston right now in asymptomatic patients. We are doing sort of mandatory COVID screening 48 to 72 hours before cases. So all of our patients are getting swabbed. And as long as they're negative, we're sort of proceeding assuming they are COVID negative, and we are using sort of just regular PPE. And we don't need to use N95s in those cases, although many of us still are. And if patients are swab positive, we're still delaying the cases for at least 14 days. So that's sort of how we're handling it right here. We're not doing full screening, sort of routine care just yet, but we're getting close to that.
Yeah, so maybe we can tag team the questions while you were answering that. A bunch of excellent questions have come through. So there's one that says, are SARS-CoV-2 IgG tests, so the serology test for COVID-2, less accurate for IBD patients on immunosuppressants? So kind of maybe a difficult question to answer because I don't know we have data, but I guess, Jess, what's your thought on that? Is serology less accurate in immunosuppressed patients?
Yeah, I think that's a great question. I think we'd all love to know the answer to that question. I agree there's limited data, but I do think it is something that people in the field are thinking about. I know there are groups at Penn and others who are starting to collect data on, with antibody testing in our IBD patient population. So I do think we will be able to answer that question. I think we all want to know, one, can anybody mount true immunity to this disease? I think we actually don't really still know that yet, and how persistent is that? And are our IBD patients more or less likely to do so? So I do know there are groups who are working on validating tests and are going to be collecting sort of more robustly, specifically in IBD patients, both on and off immunosuppressive therapies. So I do think that information in a more robust way is coming, but I don't think we can answer that fully just yet.
Yeah, and I agree. No, I agree. I think the whole issue around serology and sensitivity and specificity independent of immunosuppressants, I think is a kind of a hot topic. So whoever asked that, stay tuned. I'll take maybe the next question, and then we'll keep going through some of these. So the question I see here is for patients on oral steroids who cannot be discontinued and need to change to parenteral steroids. Do you have guidance? So a minute ago, when you asked me just about doses of steroids and trying to use 20 milligrams or less of prednisone, one thing that I think the practical reality is we need to treat a flare in any way that we think is adequate. So just because we're living in a pandemic, if a patient's flaring badly and is coming to the hospital, say for sick ulcerative colitis, and you feel that 60 milligrams of IV salumedrol or methylprednisolone is required, we still give that. I think it's just it behooves us to try to limit the high doses, which we do anyway. So just because it's a pandemic, we are still using pretty much all treatments. That's different if they actually have COVID-19, then we really try to limit the dose of steroids. But somebody who's on oral transition to parenteral, we don't change that.
I completely agree. And I'm just seeing, I'm scrolling back earlier. I think I missed an earlier question. What are the criteria for an IBD patient to be eligible for home infusions? I think a very timely question because, as I'm sure many of you experienced, a lot of our patients sort of wanted to move to home infusions or were requesting home infusions, I think, right when this all started. And so I think the criteria we were potentially using during this epidemic might have been slightly different than what we were doing beforehand. I I'll answer, and then I'm certainly curious to hear what you think, Miguel. I would say, generally speaking, for many of our patients, I liked to get them through at least the loading doses to ensure that they tolerated it, to make sure they didn't have any drug reactions, and that, to really make sure we had them on the correct dose. I often find sometimes getting drug levels is a bit more challenging when patients are at home infusions, though not impossible. And so once I felt good about the dosing and their tolerance, then I feel very comfortable, especially with the system we have up here for home infusions. I can tell you many of our patients were going straight to home infusions during this sort of period of time, which was not typically my norm, but we were certainly doing that and having good outcomes. And I do think that the home infusion services really have met the challenge of the increased volume of patients we've had over the last couple of months. Although that being said, I think our infusion units are excellent, and I don't think there's a need to be going to home infusions right now. I think the safety protocols we have in place are great, and I certainly reassure my patients of that, although I certainly understood the anxiety around sort of coming into the hospital setting over the last few months.
Yeah, so I would say a similar answer. I think, first of all, if you need to use an infusion-based therapy and you think that that's the right treatment for your patient, do not hesitate giving that infusion, and do not hesitate doing it in an infusion center. As Jess said, I think that a lot of our infusion centers are now set up in a very safe manner. The other thing is, don't switch to sub-Q, and don't necessarily switch to home infusions just because of the pandemic. If there are other reasons to do that, do that. But I otherwise completely agree with Jess. Interesting next question. Maybe I'll take this, and then Jess, you can chime in. Do you think COVID-19 clinical presentation in IBD patients has varied depending by U.S. area? That's an excellent question. I think the answer is yes, but it's more that I think COVID-19 clinical presentation is different in different parts of the country. When you look at the IBD Secure Registry, I'm not certain that we could say that the disease itself in IBD is different, but I can tell you I think that the outbreaks and severity of COVID-19 are different, say, between New York City and Cleveland and different parts of China and Italy. So I think that those are factors, and there's some question as to whether or not they're different viral strains and different immunogenic reactions. But yes, there are differences in COVID-19 geographically. I'm not sure we say that necessarily in IBD specifically, but Jess, I don't know what your thought is.
Yeah, I completely agree. Again, I think it has a lot to do on, it may have to do with strains, and it also just has to do with sheer, volume and prevalence. Obviously with high volumes of patients, you're going to have certainly more severe cases and in these high density areas. Among the IBD patients, though, again, when we look at the Secure Registry, you also have to remember it's biased based on who is inputting patients. And so you may see some skewed geographic input based on, where people are who are actually inputting the data. So I always say when you're looking at that registry, just remember it relies on people actually putting in data. So take that into consideration. But I agree. I agree that I think COVID is dependent on area, but we haven't necessarily seen, or from what I've seen and what I've read, necessarily IBD differences. And we are still, I think the data is evolving, but we are still trying to understand what COVID does to IBD disease activity. And we're starting to assess that in our patient population, and we haven't really seen any significant flares or a signal towards that post-COVID, although I think that area is also still evolving.
And I see, no, I think you and I think alike. I see one last question. I think we're getting close to 4 o'clock, and this is a tough question. I'll try to answer it, and then Jess, maybe we'll end with you and then wrap up, as I don't see any other questions yet. So what's the intestinal and plasma ACE2 pattern in IBD? So we really appreciate that question. As you know, the ACE2 receptor is, as Jess was talking, has shown that this is what the actual virus binds to. The specific question is whether or not ACE2 patterns in IBD are different. Dermot McGovern, for those that might know who he is on the line, is a really good researcher in IBD who's actually looking at this specific topic. I don't think he's published anything yet. I think the answer to this is stay tuned. It's a very interesting question. I'm not aware of any data yet, unless, Jess, you have information.
No, I was going to completely agree. I know that Dermot is looking into this, and I think the area that's also somewhat evolving that may be a particular interest in our IBD patients is they're now starting to identify live virus potentially in stool. And so, again, sort of the question around the fecal-oral route of transmission, and if patients clear their nasal swabs but are still potentially shedding in their stool, is that at increased risk for our patients with GI diseases? So I do think that's, again, an area that is certainly evolving, but of great interest to us in IBD.
Right, so a lot to learn. So we really appreciate everybody's attention on behalf of Dr. Allegretti and myself. Thank you for joining us today. Hopefully you learned something, and stay safe, stay well. Jess, I hope to see you soon.
Absolutely. Thank you, everyone.